Welcome to the e-learning module on WHO classification of epithelial tumors of ovary. In this section, I'll be telling about mucinous, endometriod, and clear cell tumors. The objective of this section are to describe the features of mucinous, clear cell, and endometriod tumors of ovary, and to differentiate benign, borderline, and malignant tumors in this category. Coming to mucinous tumors can be benign, borderline, or malignant. Benign tumors can be cystadenoma or adenofibroma depending upon the amount of desmoplastic stroma. Whereas borderline tumor are called as mucinous borderline tumor, also called as atypical proliferating tumor. Malignant tumors are mucinous carcinoma. Mucinous cystadenoma. These tumors are benign cystic tumors lined by mucinous gastrointestinal or Mullerian type of epithelium, and rarely they can have prominent fibrous stroma, which is called as adenofibroma. They are usually unilateral tumors. In this gross picture, the first one is a cystadenoma, which is having multilocular cyst with abundant mucinous material. Second picture will show predominantly solid area with cystic area, which is a adenofibroma. This is a microscopic picture where there are benign mucinous glands lined by tall columnar cells having basally located nucleus and apical mucin without significant nuclear atypia. They can be associated with some other findings like dermoid cyst or Brenner tumor, and whenever there is rupture of the mucinous gland, they can be associated with mucinous granuloma. Prognosis is very good. Cystectomy is a surgical treatment of choice. Sometimes there can be recurrences whenever there is rupture of the cyst. Coming to mucinous borderline tumor, by definition, these tumors are having architectural complexity. That means it can show stratification, tuffing, and papillary architecture, and it is a non-invasive tumor with gastrointestinal differentiation. This complexity should be seen in more than 10% of the tumor surface area, and this should not be any severe nuclear atypia, and there should not be any stromal invasion. If complexity is seen in less than 10% of the tumor surface area, they are called as mucinous cystadenoma with focal epithelial proliferation. Usually they are unilateral tumor. If it is bilateral, you have to rule out metastatic mucinous tumor. On gross, these are unilateral multilocular cysts, and adequate sampling is very important to rule out microfoci of invasion. And usually when the tumor is less than 10 centimeter, you have to give 1 section per centimeter. 1 centimeter. If it is more than 10 centimeter tumor, you have to give 2 sections per each centimeter. This is the microscopy of borderline tumor where you can see multiple cysts having architectural complexity with papillae, branching papillae. And on high power, you can see nuclear stratification and mild nuclear atypia. There are variants in mucinous borderline tumor. Whenever there is nuclear atypia is severe, they are called as borderline tumor with intraepithelial carcinoma. And if there is an invasion involving less than 5 millimeter of surface area, they are called as mucinous borderline tumor with microinvasion. So this is the case where you can see mucinous glands which are lined by cells which are showing severe atypia. They are having hyperchromatic nucleus, prominent nuclei, and very angry looking cells. So these are called as tumor with intraepithelial carcinoma. And if there is an invasion into the adjacent stroma which is less than 5 millimeter, like in this case, they are called as microinvasive carcinoma. Some of the cases can show nodules of sarcoma like connective tissue or anaplastic carcinoma like stroma. They are called as mural nodule. They can be single or multiple, and the size can vary from microscopic to 10 centimeter. So this is a microscopic picture of mural nodule, sarcoma like, where you can see spindle cells surrounded by multinucleated giant cells. On immunohistochemistry, they are CK7 positive like any ovarian epithelial tumors. ERPR is negative. Prognosis is good, but adequate sampling is important to rule out any mucinous carcinoma. Coming to mucinous carcinoma, These are invasive mucinous neoplasm with gastrointestinal type of cells. They constitute around 3 to 4% of ovarian cancer, and when they present, they usually are localized to the ovary. That means stage 1. On gross, you can see a cystic tumor with some papillary projection. You can see some solid areas. On microscopy, there are two patterns, expansile or confluent glandular pattern or infiltrative pattern. So this is the first pattern where you can see multiple back-to-back arrangement of the glands. Whereas second pattern is an infiltrating pattern where you can see atypical glands surrounded by abundant stroma. Whereas in first pattern, the stroma is less. On immunohistochemistry, they are CK7 positivity. CK20 can show variable positivity, but usually they are CK20 negative. They can be associated with KRAS mutation or HER2 amplification. So main differential diagnosis for mucinous carcinoma is metastatic mucinous carcinoma. They are usually in stage 1, so the prognosis is favorable. So how to differentiate primary ovarian mucinous carcinoma from metastatic tumors? So primary tumors are usually unilateral and the size is large, more than 20 centimeter. Whereas metastatic tumors are usually bilateral and the size is small, that is less than 10 centimeters. So small size mucinous carcinoma, you should rule out metastatic ovarian cancer. On histopathology, primary tumors will show two patterns, confluent glandular pattern and destructive stromal invasion, and they often lack surface involvement, that the cortical involvement is not there. Whereas in metastatic tumor, they show predominantly cortical involvement. So whenever there is cortical involvement, predominantly you should suspect metastatic tumor. Immunohistochemistry will be very useful in differentiating primary from secondary or metastatic tumor. Like primary ovarian cancer will show CK7 expression greater than CK20 expression, and occasionally they are PAX8 positive. So it is very useful when the tumor is PAX8 positive. So PAX8 positivity will tell that it is a primary ovarian cancer. So among metastatic tumor, you can differentiate from lower GI or appendicular neoplasm by SAT-B2. So in the lower GI or appendicular carcinoma, they will be SAT-B2 positive, and it is CK20 will show more than CK7 positivity. Whereas upper GI tumor, the expression is same as that of primary. So it is very difficult to differentiate upper GI malignant metastasis. Pancreatic tumor will show loss of DPC4, and if it is endocervical origin, means if it is HPV related, then P16 positivity will be helpful in differentiating primary from metastatic endocervical carcinoma. But if it is non-HPV related, it is really difficult to differentiate primary versus metastatic. Coming to endometrioid tumors, benign tumors are cystadenoma, adenofibroma. Borderline tumor are called as endometrioid borderline tumor. Malignant tumors are endometrioid carcinoma. So the pathogenesis is associated with endometriosis. So endometriosis can lead to either endometrioid tumor or clear cell tumors. The benign tumors are endometrioid cystadenoma. So these are cystic lesions which are lined by benign endometrioid type of epithelium which lacks endometrial type of stroma and also vasculature, that of endometriosis. So this is a gross picture. You can see a cystic lesion filled with hemorrhagic material and also occult hemorrhages foci you can see on gross. On microscopy, you can see multiple endometrial type of glands surrounded by stroma, fibroblastic stroma. So in it is the important DD is endometriotic cyst, which is a cystic endometriosis. So how to differentiate? Endometriosis lacks the fibromatous stroma. Like in this case, endometriosis will not have dense fibromatous stroma, and also there will be evidence of recent or remote hemorrhage in case of endometriosis. Or you can see endometrioid type of stroma in case of endometriosis. So coming to borderline endometrioid tumor, so these tumors are composed of crowded endometrioid glands which are lined by atypical endometrioid type of cells which lacks destructive stromal invasion or confluent glandular growth. So this is a gross picture of borderline tumor where it is predominantly cystic, but you can see multiple papillary projections. On microscopy, there are two patterns, adenofibromatous pattern, which are having glands surrounded by abundant fibrous stroma. Second is intracystic pattern, which will have cyst having multiple glands and papillae. Some of the cases can show squamous nodules. Prognosis is good and they usually present with stage 1. So surgical staging is not really necessary according to previous studies. Coming to endometriod carcinoma, these are malignant epithelial tumors which will resemble endometriod carcinoma of the uterine corpus. So 85 to 90% of these cases are associated with endometriosis and they can show PTEN mutation and beta-catenin mutation. On gross, they are solid to cystic tumor varying size from 10 to 20 centimeters with areas of hemorrhage and necrosis. Microscopically, you can see confluent glandular pattern which is of more than 5 millimeter size and there is back-to-back arrangement of the glands. 30 to 50% of endometrial carcinoma can show squamous differentiation and mucinous differentiation can also be seen. Some of these cases can also show sex cord stromal type pattern, which is called as certuliform endometrial carcinoma. These carcinomas are graded according to FIGO grading system, which is therefore endometrial carcinoma of uterus. So this is the picture of certuliform endometrial carcinoma, which is showing certuliform glands. So 5 to 10% of endometrial carcinoma can show coexistent tumor in the uterus also. So how to differentiate whether it is metastatic tumor? So whenever both the tumors are of low grade and if there is histological dissimilarity between the tumor type and if the invasion is only superficial in the myometrium in the uterus, that is less than 50%, if there is no vascular invasion or the adjacent endometrium in the uterus is showing endometrial hyperplasia, this will support that these are synchronous tumors occurring separately in ovary or in the uterus. And in case of ovary, if it is unilateral with no surface involvement, if there is background endometriosis with no vascular invasion, it will suggest a synchronous ovarian carcinoma. But if it is a bilateral involvement or if it is a multinodular growth, it will suggest that it is a metastatic tumor. On ISC, they are CK7 positive and ERPR positive. WT1 is usually negative, which is a serous marker. NAPSIN is negative, which is a marker for clear cell tumors. The prognosis is good and it is favorable wherever there is squamous differentiation. So main prognostic factor is FIGO staging. Coming to clear cell tumors, the benign tumors are called as cystadenoma or adenofibroma. Borderline tumors are called as clear cell borderline tumor. Malignant tumors are called as clear cell carcinoma. The cystadenoma are cystic tumors having small round glands lined by bland clear cells having hobnailing. So 70% of clear cell tumors can be associated with endometriosis and grossly they are solid to cystic tumors having sponge-like appearance. The size can vary from 3 to 15 centimeter. This is the benign cystic tumor of clear cell category showing glands lined by clear cells with hobnailing feature surrounded by fibrous stroma. Clear cell borderline tumor are characterized by glandular crowding with low-grade nuclear atypia and without stromal invasion. They are usually unilateral tumor and microscopically there is glandular crowding and cellular stratification. As in this picture, you can see there is crowding of the glands with stratification of the cells and mild nuclear atypia can be seen. Coming to clear cell carcinoma, these are invasive tumors which are having clear cells with hobnailing and also they can have eosinophilic cytoplasm also. The patterns can be tubulocystic, papillary or solid pattern. So 50 to 70% of these cases are associated with endometriosis and some of the cases can present with paraneoplastic syndrome like hypercalcemia or venous thromboembolism. Grossly, these are large tumor with the solid and cystic areas. Areas of hemorrhage and necrosis can also be seen. On microscopy, you can see multiple tubules which are lined by clear cells with hobnailing. So this is the glandular pattern, this solid glandular pattern. This is a tubular pattern. Here in this picture, you can see the glands which are lined by typical hobnailing cells, which are having abundant clear cytoplasm. So hobnailing is a characteristic feature. So this is the papillary pattern where multiple papillae can be seen with hyalinized stroma. They are also lined by hobnailing cells. So 46 to 57% of these cases show ARID1A mutation. Some of the cases can show PI3K mutation or PTEN mutation, but there is no association with BRCA mutation. On immunohistochemistry, they are CK7 positive, but specific marker is NAPSIC-A and HNF1 beta to differentiate from other carcinomas. ERPR is usually negative. WT1 is also negative. To summarize, epithelial tumors of ovary can be categorized as benign, malignant, or borderline tumor. To call the tumor as borderline, there should be architectural complexity with stratification involving more than 10% of surface area. If it is less than 10%, it is called as benign tumor with focal epithelial proliferation. And in all ovarian cysts, extensive sampling is very important to rule out invasive carcinoma. And also you have to collect clinical detail for correct diagnosis. These are my references. Thank you.